Welcome to AETCM, the emergency medicine channel. Today let us discuss about acute adrenal crisis. We know that adrenal gland, it's a small triangular gland situated on top of each kidneys. It has got two parts, the adrenal cortex, adrenal medulla. So they produce various types of hormones, but for an emergency physician, it is mainly the adrenaline, noradrenaline type of hormones. They maintain our blood pressure, fluid and electrolyte balance, all these things. So that is the importance of adrenal gland in emergency room. Adrenal cortex, the outer region, is the largest part of adrenal gland. It is divided into two different zones: zona glomerulosa, zona fasciculata, zona reticularis. So you can remember it as GFR. Each zone is responsible for producing various types of hormones. Adrenal cortex, it's a part of hypothalamic pituitary adrenal axis. It secretes steroid hormones important for the regulation of long-term stress response, blood pressure, blood volume, that is volume retention or volume removal, sodium retention, sodium removal, nutrient uptake and storage, fluid and electrolyte balance, inflammation. Hypothalamic pituitary adrenal axis. Hypothalamus secretes corticotropin releasing hormone, that is CRH. In the anterior lobe of the pituitary gland, CRH stimulates the secretion of adrenal corticotropic hormone, ACTH. The cortex of the adrenal gland will then produce glucocorticoids or cortisol as a response to ACTH. So this cortisol, or we give it as steroid from an external steroid we give sometimes to maintain the fluid balance or in the management of hypertension. But the hormone produced in our body is cortisol. That has a stress response. That means whenever we have a stress, more cortisol will be produced. And suppose you have the patient is having sepsis. When there is sepsis, actually the cortisol level sometimes go down. Hypocortisolism occurs. So you can get hypotension. Initially we may treat the patient with fluid, noradrenaline. Noradrenaline is a type of drug which improves the blood pressure, heartbeat, cardiac output and all. If that is also not improving, that drug is also not able to improve the clinical parameters like BP is not improving, pulse is not improving, then we can give steroids. So steroids are the third line drug in most of the shock because all these conditions, sometimes the stress hormone release will not be adequate. Most of the time the stress hormone release will be adequate. That's why we are not developing hypotension, shock or bradycardia and all when there is a stress. But sometimes this will become inadequate, the secretion will become inadequate. So we will have to give external steroids, we will have to give IV hydrocortisone or other drugs. So adrenal gland secretions, if you see, there are different types of glands. We will not go to all types of hormones, but there are some hormones which are very important for ER physician. One is glucocorticoids. It raises glucose level of blood, stimulates glucose production by cells, reduce the inflammatory response. So that is this reduction in the inflammatory response is very important. Whenever we have some illness, normally some amount of glucocorticoids will be released from our body. That reduces the inflammation. But sometimes, for example, rheumatoid arthritis, this inflammatory response will become uncontrollable type of inflammatory response or dysregulated inflammatory response. In that condition, we will have to give steroids to control this inflammation. So that is the action of glucocorticoid. Mineralocorticoid, they act in the distal convoluted tubules of renal nephrons. regulates uptake of the sodium and acid balance. So that is very important for an ER physician, because many a times these patients will come with hypotension. The problem in that hypotension may be the reduction in the mineralocorticoid activity or production. So that is also important for us. Sex hormones, it is not very important for an emergency physician, but however it is there. Small quantities of sex hormones are produced there. We will not go to that area. Adrenal, noradrenal, these are the most important hormones produced in human body to maintain our hemodynamic status. That is produced by adrenal medulla. So physiologically it produces fear, fight, fright response. So whenever we have anxiety, fear, any illness for example asthma, somebody is having asthma, or in that condition the small amount of adrenal medulla hormones like adrenal, noradrenal will be released. So that will produce some bronchodilation. Same type of drugs we use in clinical practice like salbutamol. Sometimes we give even adrenal nebulization, or when there is hypotension, body will try to release adrenal, noradrenal. That improves the body that improves the BP. Same type of drugs we give in clinical practice. If somebody is admitted with hypotension, we give fluids, then we give noradrenaline infusion. So these type of hormones will try to maintain our hemodynamic integrity or status. Same type of drugs we give in our clinical practice to maintain patients' hemodynamic status, especially hypotension, shock, hypoglycemia, all these things. These drugs are very useful. But hypoglycemia as such, we don't use steroids as first line drug. But some patients, when we give steroids, the sugar increases. So that is also a knowledge. If you are giving steroids continuously, then this patient will have hyperglycemia. So if the patient is on insulin, we have to increase insulin dose. If the patient is having OHA, we have to increase the drug dosage. Now if the patient develops adrenal insufficiency due to any reason, the most important clinical finding will be hypotension. We have already seen that volume status will not be maintained. So hypotension is the most important factor when there is adrenal insufficiency, but there are other features also. So there are different causes for adrenal insufficiency. We will not go to the details of these factors. Primary adrenal insufficiency, raised ACTH will be there. Addison's disease, that is one of the common disease which can produce primary adrenal failure. Secondary adrenal failure is seen in decreased ACTH conditions. Now third one will be withdrawal of supportive glucocorticoid therapy. That is one of the most important secondary adrenal insufficiency we treat in emergency room. So the scenario will be like this: patient may be on long-term steroids. Suddenly they skip some doses of these steroids. They go to hypotension, shock and all. Second scenario is patient is having replacement hydrocortisone therapy for primary or secondary adrenal insufficiency. Suddenly patient develops a stressful condition like a surgery, trauma or a sepsis. So immediately the need of steroids will increase. So if you don't advise the patient to increase the dose automatically, this patient will develop adrenal insufficiency, hypotension, shock. Hypopituitarism due to hypothalamic pituitary disease, that is a fourth one. But we will not go to the details of this type of syndromes. That will take longer time. To explain all these things, we need more classes. Causes of adrenal insufficiency, you can remember as mnemonic for this is Addison's. Autoimmune, that is Addison's disease. Degenerative disease, that is one of the important condition, amyloidosis, but it is not very common. Drug withdrawal is the most important cause for adrenal failure in emergency room or in ICU. That is steroid withdrawal. Drugs like ketoconazole also sometimes produce this, but ketoconazole, you all know, nowadays we don't use much in clinical practice. So steroid withdrawal is the most important reason for adrenal insufficiency in emergency room. The fourth one is infections. Infection, in that two important conditions. One is HIV, that classically involves the adrenal gland and adrenalitis, adrenal failure it can produce. TB is another important thing. If you take worldwide causes for adrenal insufficiency, TB is the maximum number of cases you are going to get. But if you take only developed countries where TB is less, then Addison disease is the number one cause. If you see some standard textbooks, TB will not be there as a major cause for Addison's disease. That is because these cases are not reported. Because they are from third world countries, the reporting system may not be adequate. But Addison disease, most of the time these cases are strictly reported, or they are all well documented. That's why many books give Addison disease is the most important cause. But if you see in our country where TB is very, very common, TB adrenalitis is also very common. So whenever a patient is having tuberculosis, if the patient come to emergency room or ICU with hypotension, shock, the most important cause will be TB adrenalitis. In that case, you have to give steroids first itself. So that is a important message from this slide. Secondary hypopituitarism, that we have seen already, decreased ACTH level can be there. Others like adrenal bleeding, like any infection, snake bite, all these things, sepsis, neoplasia of the adrenal gland. So primary adrenal insufficiency, raised ACTH, present with hypotension, acute circulatory shock, that is called as Addisonian crisis. Anorexia may be the early feature, with progresses to nausea, vomiting, diarrhea, sometimes abdominal pain. The crisis may be precipitated by intercurrent infection, stress, or a surgery. So the problem with adrenal crisis is many times patient may be slightly having weakness, vomiting tendency, abdominal pain, but most of the time this adrenal insufficiency will not be recognized. But sometimes if the patient patient commit an accident, road traffic accident, or a post-surgical period, or a stressful condition like myocardial infarction, patient develops sudden hypotension. So that is a major scenario. Hypopigmentation is very, very important, and hyperkalemia, volume depletion occur only in primary adrenal failure. So remember, one of the major differentiating feature of primary adrenal failure is hyperpigmentation. You can see in the oral cavity, you can see the skin, you can see the palmar creases will become more darkened, you can see the old scars will become hyperpigmented. So oral cavities, hyperpigmentation is also very, very important. Patients with primary adrenal failure usually have both glucocorticoid and mineralocorticoid deficiency. In contrast, those who have secondary adrenal insufficiency have intact renin, angiotensin, aldosterone system, so they will not develop hypotension, shock and all like primary adrenal failure. Secondary adrenal insufficiency, patient with secondary adrenal insufficiency have many symptoms of signs of primary disease, but not hyperpigmentation. Patient with pituitary insufficiency have manifestation of multiple hormone deficiencies. Other important finding will be primary adrenocortical insufficiency is normal aldosterone level and normal potassium. So potassium is high in primary, potassium is normal in secondary. But sometimes what happens is, if suppose the patient is having secondary adrenal insufficiency, if the patient is having severe vomiting, that itself can produce hypokalemia. If the patient is already having a renal failure, that can produce hyperkalemia. So you cannot go only according to the hyperkalemia or hypokalemia pattern. Sometimes in clinical scenarios, this can have a mix of both the conditions. Secondary adrenal insufficiency may be caused by hypopituitarism due to hypothalamic pituitary disease, or may result from suppression of the hypothalamic pituitary axis by exogenous steroids or endogenous steroids. Glucocorticoid treatment can also suppress the hypothalamic pituitary adrenal axis. That's why we tell glucocorticoids, if you are giving inflammatory doses like asthma, give only one time in the morning. Otherwise, if you give morning and evening, it is going to suppress your hypothalamic pituitary axis. So it will reduce the next day's adrenal release. So we have to be very careful. If you are giving for inflammatory response, you give only single dose. But if you are giving for a replacement therapy for adrenal insufficiency, morning and evening has to be given, because the normal axis is not working there. Missing dose of daily steroids for more than 24 hours can itself produce adrenal crisis. That is very important. So if somebody is taking steroids for a long time, every day they have to take. If they miss 1 or 2 days, they will go to hypotension. So any condition where there is requirement of an increased cortisol secretion, like patient is having surgery, trauma, myocardial infarction, just double the dose, just increase the dose, then call the endocrinologist and adjust the dose according to the lab investigation. So as a ER physician, we have to just increase the dose in a stressful condition. If the patient is having steroids, taking steroids for a long time, suppose patient has missed 1 or 2 doses, you just give 100 milligram hydrocortisone stat, because we will not get time if the patient develop hypotension, shock and all. It will be very difficult to treat that type of hypotension, because we have to give fluids, noradrenaline, then steroids. Instead of that, immediately, if there is no contraindication, give steroids. Sheehan syndrome is a postpartum acute intrapituitary hemorrhage. If there is both ACTH and growth hormone deficiency, patient may present with episodes of hypoglycemia. Secondary hypothyroidism is usually late feature of the development of the hypopituitarism. If there is isolated ACTH deficiency, the patient may present with malaise, weakness, weight loss, chronic adrenal insufficiency features. But Sheehan syndrome is very important. Patient can have prolactin deficiency that leads to failure of lactation. So that's a very important syndrome. Tertiary adrenal insufficiency is impaired hypothalamic release of CRH with resulting decreased production of ACTH by the pituitary. Causes can include brain tumors, sudden withdrawal from long-term exogenous steroid uses. So that is the most common cause. We have already explained that in detail. So primary, secondary, tertiary. Now features of adrenal insufficiency: Addison disease, glucocorticoid levels are low, mineralocorticoid levels are low, ACTH is high, adrenal androgen is low, withdrawal of steroids, glucocorticoids low, mineralocorticoids normal, ACTH normal, adrenal androgen low. Hypopituitarism, glucocorticoids low, mineralocorticoids low, normal, ACTH normal, adrenal androgen low. Clinical features, if you see weakness, tiredness, malaise, gastrointestinal features like diarrhea, constipation, anorexia, vomiting, weight loss, postural hypotension, shock, hypoglycemia, hyponatremia, hypercalcemia, hypotension, shock or acidosis, hyperkalemia, all due to aldosterone deficiency. Hyponatremia can also be there. ACTH features: hyperpigmentation due to marked ACTH excess, adrenal androgen, loss of body hair, loss of libido, especially in female patients. So first two things are very important. Hyperpigmentation is very important because Addison disease, that is a classical finding, whereas other conditions like withdrawal of steroids or hypopituitarism, that may not be there, whereas other conditions the features all are almost same. Now adrenal crisis can be precipitated by acute infection or other causes like trauma, surgery, sodium loss due to excessive sweating. Features of adrenal insufficiency you can see here: Hyponatremia can be there. You can see that lax adrenal is the mnemonic, lax sodium, acidosis, calcium elevation, potassium elevation, skin hyperpigmentation, altered mental status, depression, refractory hypotension, elevated ACTH, eosinophilia, nausea, vomiting, asthenia, loss of appetite. Now, adrenal crisis we have to manage. Whenever patient come with suspected adrenal crisis means if the patient is having hypertension, not improving with your fluids nor adrenal, then you suspect adrenal crisis. If the patient is on chronic steroid use, admitted with a major road traffic accident, patient is not improving, hypertension is not improving, you are giving fluids, blood, neurological causes are ruled out, cardiac causes are ruled out, then also patient is going to hypertension, then think about adrenal crisis. Anyway, the treatment will be same as other conditions like hypertension, other hypertensive conditions like blood loss, volume loss, whatever it is, because its main problem here it is volume depletion in the intravascular compartment due to the hypothalamic pituitary axis deficiency. The fluid should be given as normal saline 30 ml per kg initial bolus, then according to the BP response, urine output and other features like CVP and all. Noradrenaline can be started as a second line drug. If you are suspecting adrenal crisis, then immediately give hydrocortisone 100 milligram stat, and then every 6 hourly you have to give hydrocortisone, because hydrocortisone has got both glucocorticoid and mineralocorticoid action. If you are giving Dexona, it has got lesser mineralocorticoid action, but it is that action is there, but it is comparing with glucocorticoid, it is less. So hydrocortisone 100 milligram every 6th hourly. Then hyponatremia should be corrected. If the patient is having severe hyponatremia, you have to give either normal saline may correct it, oral salt may correct it, 3% may correct it. During fluid replacement, potassium levels may fall. It should be managed. So, hypokalemia can develop during the treatment, that will be corrected by KCl infusion or oral KCl supplementation. The loss of hydrocortisone is tapered gradually over many days, then changed to oral therapy. That means initially we'll be giving hydrocortisone 100 milligram every 6th hourly, then slowly reduce the dose into hydrocortisone daily 100 milligram. Then 2 doses, like normally we give hydrocortisone 10 milligram morning, 10 milligram evening, and some patients may require fludrocortisone 0.1 milligram per day if the patient does not have adequate signs of intravascular volume buildup. Then fludrocortisone can be added. So remember one important thing, in replacement therapy, hydrocortisone is given as BD dose minimum, morning and evening, but whereas in therapies like anti-inflammatory therapy like rheumatoid arthritis, SLE or asthma, any inflammatory condition, we have to give only single dose of hydrocortisone or any other steroid in the morning. But replacement therapy will be always 2 times, because there is no secretion of adrenal hormones there, so you have to give 2 times. Whereas when there is a natural secretion and you want to have an additional dose to reduce the inflammation, then give only morning, allow the next day's secretion to happen normally. So that is also very important. So we have discussed about adrenal crisis. Adrenal crisis can come to emergency room with hypertension. One of the important conditions which can occur in our country is tuberculosis, and this tuberculosis patient is coming to emergency room with hypertension, shock. The reason is TB adrenalitis. Steroids are the treatment of choice there. Then immediately give hydrocortisone 100 milligram every 6 hourly you can do. And if you want to take a cortisol, random cortisol can be taken immediately to make sure that your diagnosis is correct or not. Thank you.